during this webinar. And thank you for joining this important webinar. Over to you, Dr. Rashmi.
Thank you very much, sir. I'm grateful that I have been given this opportunity to speak on cardiovascular diseases. First of all, apologies that my video is not visible because of some technical issues. Hopefully, I'm audible and my slides are visible.
Yes, ma'am, your slides are visible.
Okay, thank you. So we will start. So today we will be discussing the diagnosis and treatment of cardiovascular diseases. And by the end of this session, we'll be able to define what are cardiovascular diseases, what are the risk factor for them, how a person presents to a clinician or anywhere if they have cardiovascular diseases, what are the non-pharmacological modalities of treatment, what is the drug treatment, and what is the role and importance of patient and family education in treating cardiovascular diseases. So first, cardiovascular disease. So I hope it was also covered in the last session that cardiovascular diseases are a group of disorder which are affecting our cardia, that is heart, which is a Greek term for heart, and vascular system, that is the blood vessel, mainly the arterial system, which are carrying the oxygenated blood. And the most important pathogenesis is atherosclerosis of these blood vessels, which causes damage to the heart and the organs which are supplied by these vessels. Now, there are many types of cardiovascular disease. First of all, it is coronary artery disease. That means there is development or deposition of a plaque. Plaque is composed of the lipids, the fibrous tissue, the platelets, and the leukocytes, and it obliterates the lumen of the vessel, as a result of which the blood supply to heart gets impaired. Second is heart failure. It can be a consequence of coronary artery disease or it may be because of other conditions. And what happens in heart failure is the ability of heart to pump blood to the body decreases. Then they can also manifest as cardiac arrhythmia. That means the beating of heart becomes irregular. Sometimes it beats very fast, sometimes it beats a bit slow. And some of the valvular heart diseases. So we have mitral valve, aortic valve, tricuspid valve. So some of the diseases like degenerative aortic sclerosis or mitral annular sclerosis, they are the result of atherosclerotic cardiovascular diseases. Then if the vessels of our limbs, that is our legs or our hands, are obliterated with this atherosclerotic plaque, we have peripheral arterial diseases and then hypertensive heart disease. So these are the key types of cardiovascular disease. Now, why is it important that we should learn about these diseases is nowadays, throughout the world, 1/3 of the mortality is because of these cardiovascular diseases. And these mortalities can be prevented if they are timely diagnosed and treated. Now, in which group of people should we suspect a cardiovascular disease? So there are certain risk factors. So the risk factors can be categorized as modifiable risk factors or non-modifiable risk factors. The modifiable risk factors are those which can be treated or maybe cured. And the non-modifiable ones are those for which we cannot do much. So in the modifiable risk factors, we have hypertension, that is a high blood pressure, hyperlipidemia, that is increased LDL cholesterol and a reduction in HDL cholesterol, diabetes mellitus, that is increase in the blood sugar levels, smoking and tobacco use, physical inactivity, obesity, BMI of 30 in the Western world and more than 27 in Indian context, excessive alcohol consumption, and poor diet. That means a diet which is rich in sodium, which is very high in saturated fat, and that lacks fibers. So these are the modifiable risk factors because we can change them. Then there comes the non-modifiable factors, that is the age, which is more than 45 to 50 for males and postmenopausal females, often around 55 years of age. If there is a family history of early cardiovascular diseases, then a person's risk for having these conditions increases, and if there is any genetic predisposition. Now, superimposed on that is a chronic stress. A chronic stress may be because of a hectic lifestyle, lack of sleep, or any chronic inflammatory condition. So what happens in this chronic stress is the sympathetic nervous system, which is responsible for our fight, flight, or fright reaction, is activated, and thus it increases the cardiac workload, and somehow our heart is not able to maintain with that. And this is most often a precipitating cause of decompensation, which causes a person to present to hospital. So if a person is having this, any of these symptoms or any of these features, and they present to us with some of the signs and symptoms, we should be thinking in terms of that maybe we are looking towards a disease which is involving the heart or the blood vessels. So what are the most common signs and symptoms? So first and most important is chest pain. Now, chest pain in cases of a cardiac condition is generally central in nature. So, as we can see in the left side of figure, this person is having chest pain and he is pointing towards the center of his chest, more towards the left side with a squeezed fist, with a fist. This is called Levine sign. Now, why is it squeezing? Because that is how the chest pain feels. It's squeezing, it is heaviness, sometimes it's a pressure. So, this is how they describe it. Now, this can radiate most often to the left side of the arm, but it can even go to the right arm, it can go up to the jaws, or maybe up to the navel, that is the umbilicus. Now, how does this pain come? This pain is generally precipitated by exertion. Exertion means some sort of exercise. So maybe a person is running or they are doing some chores, and after that they get this type of pain. Sometimes emotional stress, a condition of high emotional stress, can also precipitate this pain, and in some cases even a heavy meal can precipitate a chest pain. Now, this pain is often relieved by rest, or there is a nitrates, that is a tablet which is kept under the tongue, and it causes relief of this pain. Now, but this will happen when the person is an early course of disease. But as the disease progresses, the frequency of this chest pain will increase, the amount of exertion with which the pain happens will decrease, and sometimes the pain stays persistent. If a pain stays for more than 20 minutes, maybe we are looking at a myocardial infarction, that is normally known as a heart attack. The other most common symptom will be the symptoms of heart failure. Now, in heart failure, the ability of the heart to pump blood to the body is decreased, as a result of which our organs are not adequately perfused. So, what happens with that is, first, a person experiences fatigue. So, they're always fatigued, they want to rest more, and they are not able to do their day to day work. They have to take breaks in between. They say they are not able to exercise now, or they can be complaining that they get breathless whenever they are working or walking uphill or walking very fast or doing their day-to-day work. They become breathless. That is what is dyspnea. And if the disease has progressed too much, they can be breathless even at rest. Sometimes they can have symptoms of orthopnea. That is, when they are lying down at night, they're not able to take a breath. So they either have to increase the number of pillows. They're using 2, 3, maybe 4 pillows to keep themselves upright, or sometimes they might be sleeping in a sitting position. So this all happens because the blood is not going forwards and it is getting accumulated back in the pulmonary tissue. Now, if a person has heart failure, they often complain of swelling which is around the ankle, swelling which is around the limbs. So, as we can see in the right diagram, so the person is having a pedal edema and there are marks of the slippers on his foot. So they will be having slipper marks. If they're wearing any ring, the rings will leave a mark, or might be the rings get tight. So they also show edema. If this person goes to hospital, the doctor may be able to have some may be able to identify some signs on lung auscultation. But this is how a person will present. Now, other category is arrhythmia. As we have already talked, arrhythmia means a irregularity of heartbeat. So a person will say that they are aware of their heartbeat. So in normal conditions, when we are not very much excited, we are not running, or we are not giving a speech anywhere, so we do not feel our heartbeat. But in these cases, a person who is resting, they might start feeling their heartbeat, and this heart may be racing very fast, or they might say that they have missed a beat, and then the heart rate is very high. So they can have palpitations, which can be at a very rapid rate, that is a tachyarrhythmia, or at a slow rate, that is bradyarrhythmia. Now, whenever the heart beats at irregular rates or with an irregular rhythm, what happens is its pumping capacity is compromised. And when the pumping capacity is compromised, the blood flow to the brain reduces, and which causes the person to faint. Now, if the person is feeling a fainting episode and they sit down, so again the blood flow is resumed, and maybe they do not go to loss of consciousness, or otherwise they may have blackout and a person can even fall. Then the fourth group is peripheral arterial diseases. So here the blood supply to our limbs is affected. So what happens is there is no blood supply, so there will be pain. Whenever I'm exercising my limb, there will be pain in that limb. So pain in the legs while walking, pain in the hands or arms while doing some overhead exercises, that can happen. Also, because there is no blood supply to the limb becomes cold, it becomes very clammy, and it is very pale to look at. And if this is lasting for a longer duration, the nails may become bluish in nature. So the extremities will get cyanosed. If a person tries to examine their pulse in those limbs, so they may not be able to feel those pulses. In some conditions or in advanced condition, they might develop some amount of ulcers in the extremities where the blood supply is occluded. If the disease becomes very severe, the person may have a continuous pain in resting state. Now, one very important thing to notice is that women and diabetic patients generally do not present with typical type of inguinal pain, and they may have nausea, fatigue, or jaw pain. So we also have to be careful if a person presents with these symptoms. Now, once a person with these said risk factors presented with the symptoms as we have discussed before, then we can run a battery of tests to diagnose actually what is happening. And we also want to know what are the underlying risk factors the person is carrying. So we have to go for a lipid profile. So lipid profile to look for hyperlipidemia or dyslipidemia, HbA1c or fasting blood glucose to check for the diabetic status, then CBC, and basic metabolic profile, because we will be adding certain drugs. So we want to have our baseline CBC and basal metabolic profile. Then CRP and homocysteine levels, these are the inflammatory markers. Again, they are increased in person who are dyslipidemic, those who are diabetic. So this inflammation, if is there in the body, it suggests that we have to step up our treatment, maybe step up our non-pharmacological treatment or pharmacological treatment. Now, if we are suspecting a heart failure, we can go for a B-type natriuretic peptide value or a NT-proBNP, that is N-terminal proBNP. If there is chest pain and we are thinking in terms of myocardial infarction, we can go for cardiac enzymes, that is cardiac troponin I and T. We can also go for a ECG, very important in person who has presented to us with chest pain or maybe features of heart failure or maybe arrhythmias. So we can find out what is the cause for the chest pain. There can be an ST segment elevation, or there can be ST segment depression, or we can see some rhythm disorders like atrial fibrillation or ventricular fibrillation. If a person just presents to us with arrhythmia, we may go for a Holter monitor, because maybe by the time they present to us, the rhythm has improved. So Holter will monitor them for 28 to 48 hours. Or if that also does not picks up the rhythm, we can go for event monitors, which can be recorded for up to 7 to 10 or maybe 14 days. After that, we have got certain imaging studies like echocardiograms. So echocardiograms will tell us about the functioning of heart, the functioning of valve. They can tell us about the wall motion. So if there is a regional wall motion abnormality, that suggests that that particular area of heart is not getting perfused, and that is indicative of a coronary artery disease. We also have to look at ejection fraction, which is often reduced in cases of patients with heart failure. So normal ejection fraction is somewhere about 55 to 60. Less than 40 is heart failure with reduced ejection fraction. And then we have minimally reduced 40 to 50, and more than 50, but still features of heart failure can be a heart failure with preserved ejection fraction, often seen with hypertensive heart diseases. We also can go for a chest x-ray, which will show that the cardiac shadow has increased in size, that is cardiomegaly, or there is accumulation of fluid in the pulmonary interstitium, that is pulmonary edema. If we want to check the health of the vessels, we can go for coronary CT angiograms, which can show if there is a plaque deposition on those in those arteries. Or we can go for nuclear stress testing. That is, we make a person to exercise, or we may inject dopamine and see how the heart works when it is exercising. Then, if there is peripheral arterial disease, we can go for a Doppler ultrasound to look for the health of the peripheral vessels. If this also does not picks up, then there are invasive procedures, that is invasive coronary angiography, in which we put the angiogram, the catheter inside the blood vessels to look for the health of the blood vessels and if there is any plaque. Electrophysiological studies if a person is having arrhythmias, and rarely if there is a cardiomyopathy, they might go for a biopsy as well. Now, once the diagnosis has been confirmed, what do we need to do? Or we are thinking that a person is having, or he or she has developed risk factors. Now we want to address them. So what should we do? So there are some basic lifestyle modification everyone should follow. And these are a diet which is good for our heart health. So that is a low sodium diet. This is 2 grams of elemental sodium, which amounts to 5 grams of your salt. So around a teaspoon or a salt, which should be taken daily. More than that, the sodium has a tendency to accumulate water, and thus it increases the cardiac workload. So we should try to reduce the sodium intake. Then a Mediterranean diet. So this diet is rich in fibers. This diet is rich in fruits and vegetables, and there is less of the saturated fats, and it is 40 to 50% of the carbohydrates and proteins. So a Mediterranean diet, that is a traditional Indian platter, generally resembles a Mediterranean diet. Second is exercise, exercise of moderate intensity. So a moderate intensity exercise is the one which will not cause you to be very breathless, but the person will start sweating. They still would be able to talk in words, but they won't be able to complete their sentences. So this sort of activity like water aerobics or jogging or maybe some sort of yoga or dancing, that should be done for more than 30 minutes a day for at least 5 days a week. So maybe this amount of exercise does not help you lose weight, but it is good for the cardiovascular health. So should be continued. Now there are cardiac rehabilitation services available. Why is it done? Because a person who has developed cardiac diseases, or those who have not exercised for a very long time, it becomes difficult for them to start with a 30-minute exercise duration. So they need to gradually be introduced to this exercise regime, and for that we can refer them to a adequate physiotherapist, or if available, a cardiac rehabilitation center. Smoking should be absolutely stopped in such people or in anyone who are at risk of cardiovascular diseases. And there are behavioral support can be given by the family and with the treating medical team. And then there are certain pharmacological therapies also, but they should be given only under physician's care. We should also try to manage our weight, try avoid being overweight or obese. So targeting the BMI between 18.5 to 24.9, BMI calculated as weight in kgs divided by height in meters square. Try to avoid alcohol altogether, but if it cannot be done, or maybe a person is in the reducing dose, so it should be less than 1 drink in women and less than 2 in men. And again, stress reduction is very important. So to have a good sleep, maybe yoga or maybe a cognitive behavioral therapy, maybe talking to a friend or taking a walk, whatever helps us reduce our stress. So these are the basic things which should be done in each and every person. Now these are the drugs which some of which will be given depending upon what is the what is the clinical profile of the patient. So we have antiplatelet drugs. So these are the drugs which reduce the stickiness of the platelets, and thus the platelet is not able to aggregate and form a clot. So they are generally given in those patients who have chest pain, that is the acute coronary syndromes. Then second is anticoagulants. Anticoagulants are generally given after MI, when a person has had ST segment elevation MI, or a person is having a rhythm disorder. So there we use anticoagulants. So what they do is once a clot has formed, they will break it down and they will not allow a new clot to form. Then we have a very good group of drugs which are beta blockers. They are very good for coronary artery diseases and they do lower our heart rate. So in arrhythmias and in heart failures and post-MI, beta blockers are used. They are also a antihypertensive, though not very good, but a good, but an antihypertensive drug. Then ACE inhibitor and ARB, they are very good drugs for heart failure and they're also antihypertensive. Then statins. Statins are very important to reduce the atherosclerotic load. They reduce the LDL cholesterol and we target it to be less than 70 or less than 55 in a person who has already had a atherosclerotic cardiovascular diseases. If a person presents to us with heart failure and there is a pedal edema, they might be advised diuretics, which will increase the urinary output. So these are the main group of drugs. One more group of drug is SGLT2 inhibitors, that is dapagliflozin and empagliflozin or sotagliflozin, which are being given for patients who are having heart failure. So these are the categories of drugs which will be added in varying combination depending upon the clinical profile of the patient. Then very important is patient and family education. Now, why is it important? Because these diseases, these are non-communicable diseases and they will stick with the patient for a long time. So it is very important for them to understand that they have to take their medication and we have to explain it to them that taking medication, what good is it going to do? Then they should also be told that when should they come back to the hospital or to their physician for a re-checkup. So if there is a chest pain which is lasting for more than 5 minutes, they develop a sudden shortness of breath, or they have lost their consciousness, or there is severe headache, there is a weakness of limb, or there is a drooping of face, they should be coming to the hospital immediately. Again, as we have already said, the dietary advice should always be reinforced in each and every visit, and they should be given an adequate follow-up program. So when they have to come for their next follow-up visit. Now, there is one technique called teach back method, so that we will ask the person to teach us back what we have just explained to them, so that we have an understanding to what an extent they have understood what we have told them. We can also have patient information sheets typed, and that can be given to the patients and their relatives. So the key takeaway for today's class is that cardiovascular diseases are a major group of disorders which are happening throughout the world, and they are contributing to mortality and morbidity and loss in the daily living. So we should be able to recognize them early so that they are treated at a very early stage, so that the quality of life for the person improves. Since the treatment will be long and ongoing, they require that the person should always be encouraged to adhere to the therapy and lifestyle modification, be it a primary CVD prevention, that is, no disease has happened yet, but I'm just having the risk factor, or a secondary CVD prevention, that is, the disease has happened once, but I want to prevent another episode. So lifestyle modification is the cornerstone for all the patients who follow in this group, or maybe all those who are relatively healthy as well. So if we can follow the lifestyle, we can diagnose the symptoms early and we can intervene early, we would be able to save many lives from cardiovascular diseases. So this brings us to the end of this class. I would be happy to answer any questions.
Yeah, thank you so much for a very informative session today, ma'am. So we have now a Q&A session. So all participants attending the webinar can ask your question directly to the expert today. You can unmute yourself, raise your question, or maybe you can use the chat box to write your question there and we can pick up. Thank you.